So good afternoon. I have the pleasure to be with you with such excellent speakers and panelists and the participants from all over our area, MENA area. I'm welcoming also our chairperson for this session, Dr. Ali Shamsuddin, who is consultant hemato-oncologist at the Department of Oncology Radiotherapy in Gustave Roussy Cancer Campus in France. On behalf of the CRG, with the President Fadi Farahat and the AMAC, it's our pleasure to continue us with the ABC Oncology Educational Course, the second session on update in managing breast cancer. The activity, as you all, is endorsed by AMAC, UICC, and ASCO, and is awarded by 2 CMEs. So I will let the floor to our colleague, Dr. Ali Shamsuddin, to introduce our first speaker, and then the second speakers. After that, our panelists will discuss the lectures and they will take care about the Q&As. Don't forget that this activity, you can have it in French. Just click in the translation or interpretation so you can hear it in French. Dr. Ali Shamsuddin, please, the floor is yours.
Thank you, Professor Khatib. So it's my first time participating in the ABC Oncology Educational Course. I'm very honored, and it's my pleasure to be here tonight with you. So we're going to talk about updates in breast cancer. And the first session is going to be presented by Dr. Ali Kanj, who is the chairman of radiology department at Hammoud Hospital, Lebanon. And he's going to develop and talk about optimal imaging before and after neoadjuvant therapy in breast cancer. Dr. Kanj, it's for you.
Good evening. Thank you, Dr. Ali. Thank you, everyone. Thank you for ABC organizing for inviting us for this session. I would like to share the screen. Do you see my screen now?
Yes, we see it. Yes.
So actually, the subject today is optimal imaging before and after neoadjuvant chemotherapy. And as we know, as a radiologist perspective, we have to be satisfied with our lecture tonight. We have to answer several questions. Actually, first of all, we have to ask about the accuracy of conventional imaging modalities. We know that we have at present conventional imaging modalities like mammography, echography, and MRI, which are available everywhere worldwide, in urban, in cities, and at the peripheries, in different proportion. And we have to review together, actually, what about the accuracy of these conventional imaging modalities. Also, we have to ask about the role of whole body imaging, the role of systemic imaging in cases of breast cancer under neoadjuvant chemotherapy. Also, we have to review together the limitation and role, probable role of what we call the functional and quantitative imaging, and what is the current status of these modalities. Some of these modalities are available in our daily practice, and some of these are also under investigation. We have also to ask about the combined multimodality approach. What are the advantages of these modalities and how it could increase our accuracy? And at the end, we have to ask about the standardized reporting and response evaluation for all these questions. So first of all, you know better than us as oncologists the benefit of neoadjuvant chemotherapy and they are facts, actually. Of these facts, first of all, according to Rastogi in 2008, first of all, the reducing the size before the surgery by itself, it could convert inoperable breast cancer to resectable one, or even it could change complete mastectomy to partial mastectomy. And also another potential benefit, according to Kim in Clinical Oncology 2015, the extent of axillary surgery could be reduced, which is an important factor for pathological response evaluation. Also, of the benefits of neoadjuvant chemotherapy is the direct observation of therapeutic efficacy of systemic therapy before mastectomy, which enable us or give us the opportunity to observe the efficacy of this systemic therapy. And also another fact at present, according to von Minkwitz, that the attainment of pathologic complete response after completion of neoadjuvant chemotherapy and surgical resection is associated with improved disease-free survival. These are facts from the literature and from oncology literature and surgical oncology literature. What about the radiology? Our job, we know that, as we said before, that we have the current status or the conventional imaging modality like mammography, like echography and MRI breast. Also, we have the clinical examination, which is considered one of the conventional modalities for evaluation of breast cancer response to neoadjuvant chemotherapy. We would like to compare these different modalities. First of all, clinical breast examination. We know that according to literature that the accuracy of clinical examination by itself is something like 57%. And there are challenges with clinical examination, including the post-therapy fibrosis, the presence of dense breast, fibroglandular breast, and which could limit the efficacy and accuracy of clinical examination. For conventional first available method for evaluation, which is the mammography, the conventional mammography, in one report of 6 studies, for example, comparing mammography and ultrasonography in patients post-neoadjuvant chemotherapy, we have accuracy of 74% and 79% respectively. This is a case as we see here. We see the mass before starting, and we see here the residue of the lesion before and after chemotherapy, neoadjuvant chemotherapy. However, this is not the case always, because sometimes the breast is very dense and the evaluation on mammography could be limited. So according to literature, mammography has been shown to be more sensitive than physical examination for detecting presence of residual tumor after therapy, but is less specific and may underestimate the degree of treatment response. These are part of the limitation of mammography. Although mammography is limited by the lesion type, the association, the degree of association of architectural distortion, the margin of the lesion at the moment of diagnosis and after treatment, which could decrease actually the accuracy and the good interpretation and measurement of the residual size. In this field, actually, the advances in the conventional modality introduced what we call the tomosynthesis, which reduced the masking effect on mammography, which may improve actually the measurement accuracy of these lesions. What about the echography by itself? Echography is better predictor for tumor, pathologic tumor response. Ultrasound is the most accurate predictor of response in axillary lymph node as compared with mammography and physical examination. This is a case of a spiculate nodule on ecography. We see the spiculate aggressive pattern of the lesion before the neoadjuvant chemotherapy, and we see here the successful and efficacy of neoadjuvant chemotherapy, and with the residue is very small, and we see a small faint acoustic shadowing. What about the MRI? MRI for sure is the most sensitive imaging modality for breast cancer detection, and also is the most accurate imaging modality for assessing tumor response to neoadjuvant chemotherapy. According to combined analysis of DIX studies, the positive predictive value of MRI was something like 93%, and negative predictive value was only moderate at 65%. This is a case that we had for neoadjuvant chemotherapy before and after, and we see how MRI is beautiful in evaluating the degree of efficacy of neoadjuvant chemotherapy, and we see the huge difference in size between before and after treatment. And we could measure with accuracy the size of the lesion. This is another case also. We see the mass before and the mass after. Actually, the response is not that beautiful, and in size we have approximately same size, but mainly we have difference in enhancement pattern. There is overall good agreement between residual tumor size measured on MRI and pathologic tumor response determined after surgical excision, with some degree of over or underestimation, which is about 0.7 coefficient. There are several actually factors that could influence the diagnostic accuracy of MRI for therapy response assessment. First of all, the type, molecular subtype of the tumor is a key factor. For sure, accuracy of MRI in determining residual tumor after neoadjuvant chemotherapy is greatest in ER negative, HER2 negative, positive, and triple negative tumor, and less accurate in luminal tumor. So tumor type by itself and molecular subtypes could influence accuracy of MRI. The type of chemotherapy by itself, using taxane or anti-angiogenic drugs, also could influence the sensitivity and accuracy of MRI in detecting lesion. The pattern of tumor response also is another factor influencing the accuracy of MRI. We know that if the response is identified on MRI by fragmentation of the primitive lesion, that could underestimate the residual tumor, or even if the response is associated with inflammatory reaction, could also overestimate the lesion. Also, the use of pathologic response criteria is by itself one limitation for MRI accuracy. This is a case where actually we don't understand if we are dealing with progressive disease or overestimation on MRI. This is in June 2020, and the other one is in April 2021. And we see there is exaggeration in size of the lesion, which could be related to inflammatory response or could be related to progressive disease. This is actually a limitation of MRI in terms of specificity. So the MRI by itself, we believe that it is the most sensitive imaging modality in detecting, also in follow-up for neoadjuvant chemotherapy response. It is recommended by American College of Radiology and European Society of Breast Imaging for following the response to neoadjuvant chemotherapy, and is included in NCCN guidelines as optional tool. This is overall comparison between the different conventional modalities available now in the market between mammography, echography, and MRI. Now, what about the goal of pre-treatment imaging is for sure to determine the imaging extent of the disease for staging and to screen the contralateral breast. Also, it's important to confirm appropriate biopsy marker kit placement within the breast tumor and axillary lymph node if sampled, prior to the start of neoadjuvant chemotherapy in a complete imaging response, if in a case of complete response is obtained. Utilization of whole body imaging for initial systemic staging also is another question should be answered from radiology perspective. Where to use the whole body imaging? Actually, according to oncological guidelines and to National Comprehensive Cancer Network, Systemic imaging can be considered for patients with advanced clinical stage 2B, or advanced axillary disease, stage 3, locally advanced and inflammatory breast cancer. This could include CT scan, CT or MRI imaging of abdomen and pelvis, bone scan, or PET-CT. For asymptomatic patients with early stage breast cancer, routine systemic imaging is not indicated according to guidelines. Concerning the second part of our daily practice, which is the functional and molecular imaging, we know that the conventional radiology and conventional imaging is limited to the concept of size, to measure the size of the tumor and response. And this is a limitation because we know that systemic therapy by itself is a time-taking process to reach the steady state level, induce cellular changes leading to cell death. This requires time. And this death, it requires months to be expected or pronounced as size change. However, reliable method of early identification of tumor that are not responding would be helpful in directing these patients to definite surgical treatment and avoid continual risk of side effect from ineffective therapy. Another potential benefit would be the ability to change therapy before going surgery. These are the main objectives actually of functional and quantitative imaging. This is the main target of these modalities, application and investigation. Of these modalities, we know that we have the DCE, the dynamic contrast enhancement, pharmacokinetic and signal enhancement ratio evaluation. We have the diffusion imaging, the proton MR spectroscopy, the FDG, and the different application of PET-CT. Concerning actually the first, what concerns us as dynamic MRI, dynamic DCE, we know that this theory is not the new one. Concept of neoangiogenesis and concept of microvascularity associated with the tumor generation and imaging, targeting the identification of neoangiogenesis and the energy and material substance exchange between the cell membrane and extracellular, extravascular spaces, identification and measurement was always a goal for DCE, MRI, and geography in terms of differentiation between the different type of curves between malignant and benign curves for lesion. And this one could be helpful also for following patients with neoadjuvant chemotherapy, because effective chemotherapy reduces tumor neoangiogenesis and microvascular permeability, which occurs in part through the loss of pro-angiogenic growth factors. So this would be helpful for also identification of early response on neoadjuvant chemotherapy. However, there are limitations of the measurement which require good image quality, good measurement tool, and there is actually complex, complicated, and limited accuracy or values to determine the quantitative measurement. This is a case where we see the good response. Actually, we see here the intensity of angiogenesis or DCE values on the left breast, and after neoadjuvant chemotherapy, that we see the weak enhancement pattern of the lesion. Another case also where we see the difference and the progression. So concerning
Dr. Kenj, you have maybe 1 minute. It's very interesting, but we're a little bit late.
Okay. Second part is diffusion-weighted imaging. Also is another important functional modality. The proton MR spectroscopy, there are at present limitation for MR spectroscopy in use. It is actually sensitive for choline and lactate. The other part, for sure, we know that these are related to PET-CT and FDG PET. So we'll pass first concerning functional imaging modalities. We'll pass to combined imaging modality. Another question, if combined imaging modality would be accurate, actually, which is very important to understand that MRI may be better at assessing residual disease burden after therapy, while FDG PET may be better at assessing response during therapy. Because these studies revealed that MRI actually after completion of neoadjuvant chemotherapy was outperforming FDG PET, and during the treatment FDG was outperforming the MRI. The introduction of PET MRI was limited in the market because there were some technical actually deficiency concerning the Siever point. The challenges also in the future direction for standardized reporting, they exist, some using RECIST criteria. However, RECIST criteria are limited by subjectivity of ultrasound and mammographic reading. Some also consider the new the European Organization for Research and Treatment of Cancer, which are based on FDG uptake or the PERSIST emission tomography response criteria in solid tumor. Also, these are method used in evaluating tumor response in conventional imaging or on PET-CT scan. So what we understand at present as conclusion that surgery is still required to determine complete tumor remission, and the ultimate goal is predicting the localization of microscopic residual tumor, which may contribute to disease management without surgery using radiation or other local treatment. And unfortunately, currently we have no established clinical practice guideline for how best to assess tumor response to neoadjuvant chemotherapy. As take-home message, first of all, prior to initiation of neoadjuvant chemotherapy, diagnostic imaging should be performed for both breast with additional whole body imaging depending on disease stage. Second, the same imaging modality and protocol should be performed after completion of therapy for measurement of response, together with repeat diagnostic mammography and or ultrasonography for pre-op localization planning if breast conserving surgery is planned. Third, dynamic contrast enhancement MRI breast offer the highest diagnostic accuracy in primary tumor therapy response assessment among the currently established methods. Fourth, the functional and molecular imaging using advanced MRI techniques and or radionuclide imaging are emerging methods for assessing physiologic changes induced by treatment and may indicate response earlier than anatomic-based imaging. And at the end, prospective response-guided clinical trials are needed for sure to demonstrate that use of functional and molecular imaging to guide neoadjuvant chemotherapy improves patient outcome before widespread clinical adoption can occur. Thank you very much.
Thank you, Dr. Kanj, for this interesting presentation. So now we move on with Dr. Bassem Youssef. He's an assistant professor of clinical radiation oncology, Department of Radiation Oncology of AUB, Lebanon. So Dr. Youssef, he's going to talk about radiotherapy issues after neoadjuvant chemotherapy in breast cancer. Thank you, Dr. Youssef.
Thank you, Dr. Ali. Good evening, everybody. It's my pleasure to participate in this excellent webinar, and I want to thank the organizing committee for the invitation. Can you see my screen or not yet?
Yes, we see it.
Yes, it's okay.
Okay, the title of my presentation is Radiotherapy Issues After Neoadjuvant Chemotherapy and Breast Cancer. This is the outline of my presentation. I'll start with a quick introduction, and then we'll move to the role of radiation therapy and after neoadjuvant chemotherapy for both after breast conserving surgery and after mastectomy. So as a quick introduction, in breast cancer, neoadjuvant chemotherapy allows the early targeting of both systemic and locoregional sites of disease. Neoadjuvant chemo leads to pathologic downstaging, which has a couple of benefits, including patients who initially require a mastectomy can eventually be amenable for breast-conserving surgery after downstaging. And also it helps the avoidance of an axillary lymph node dissection for select patients with clinically node-positive disease who achieve complete pathologic response. And finally, it enhances our ability to tailor and limit our subsequent locoregional radiation therapy. Starting with the role of adjuvant radiation after breast-conserving surgery. Now, we have to say that always adjuvant radiation is indicated after a breast-conserving surgery because at least we have to treat the breast. And regardless of the response to tumor, even after complete pathologic response, we have to do it. For patients who present with stage 3 disease and those who have residual positive lymph nodes, we are required to treat the whole breast in addition to the regional lymphatics. Now, for patients who present with stage 2 disease and achieve a pathologic complete response, we individualize our approach for regional nodal irradiation, weighing the patient and tumor risk factors. For example, we are more inclined to treat a young patient or a patient with ER/PR negative disease, etc. The ongoing NSABP trial will help address this issue as well. Now, the more interesting part of the presentation is the role of adjuvant radiation after mastectomy. The indications for post-mastectomy radiation after neoadjuvant chemo are the following. For patients who have locally advanced disease, stage 3, most of them will require post-mastectomy radiation even after a complete pathologic response. As well, for patients who have residual nodal disease after neoadjuvant chemotherapy, post-mastectomy radiation is required. Now, for patients with stage 2 disease who achieve a complete pathologic response, there is room for the omission of post-mastectomy radiation in a select group of patients. Now, on the right, I show a radiotherapy plan. A typical radiotherapy plan would entail treatment of the chest wall plus the regional lymphatics, including the infraclav, supraclav, plus or minus the internal mammary chain. So this probably is one of the most important studies that looked at the role of radiation for patients who achieve a complete pathologic response after neoadjuvant chemotherapy. It's a retrospective study from MD Anderson, published in 2007 in the Red Journal. It included 106 patients who were treated with neoadjuvant chemo followed by modified radical mastectomy who achieved a complete pathologic response. Now, the stages at presentation were early stage, stage 1 and 2, and third of the patients. The rest had the stage 3 disease. Now, post-mastectomy radiation improved the outcomes for the patients with stage 3 disease, as we can see. On the left side of the slide, we can see that the 10-year rate of local regional recurrence was only 7.3% for those who had radiation versus 33% for those who didn't. The 10-year distant metastasis-free survival was 88% for adjuvant radiation versus 41% for none. And finally, overall survival was as well improved, 77% at 10 years versus 33%. Now, when they looked at the patients with early stage disease, the use of radiation therapy did not affect the 10-year rate of local regional recurrence. And actually, it was 0% for both arms. Now we move on to another important study published by Mamounes et al. In JCO in 2012. It looked at the predictors of local regional recurrence after neoadjuvant chemotherapy. It's a combined analysis of two NSABP neoadjuvant trials, the B18 and the B27, that included around 3,100 patients. The neoadjuvant chemotherapy given was idriamycin cyclophosphamide plus or minus taxotere. The patients who had a lumpectomy received radiotherapy only to the breast. None had regional nodal irradiation. As for the patients who had a mastectomy, they did not receive any radiation therapy. Now, on this slide, I illustrate the importance of treating patients who have residual disease in the lymph nodes after neoadjuvant chemotherapy. On the left side, I am showing the results for patients who had a mastectomy and who had a tumor less than 5 centimeter in size and who had positive residual lymph nodes. The 10-year risk of locoregional recurrence was 17%. The same was true for the patients who presented with a big tumor, more than 5 centimeter, and who eventually were found to have residual nodal disease. The 10-year rate of locoregional recurrence was 22%. So it is very important to treat all of these patients because of the high risk of recurrence. Now moving on to the same trial, but for patients who had early stage disease, like stage 2. So those, they have a low risk of locoregional recurrence if they achieve complete pathologic response. When we look at patients who presented with clinically node-negative disease and who achieved a pathologic complete response, the 10-year locoregional recurrence was very low, 6.5%. The same applies for those who presented with clinically node-positive disease, and their 10-year locoregional recurrence rate was 0. Now, we have to mention that the number of cases was very little, 46 and 21, and this should be kept in mind. Now, caution is needed for patients with hormone receptor negative disease. In a trial by Cantor et al. Published in the Journal of Surgical Oncology in 2016, they used the National Cancer Database to assess the role of post-mastectomy radiation after neoadjuvant chemo. And for the entire group, there was a benefit for adjuvant radiotherapy. For those with clinical N1 disease, the 5-year overall survival was 75.8% versus 71.9%, with a significant p-value of 0.01. For those with clinically N2, the 5-year overall survival was around 70% versus 58.6%. When they looked at the patients who had a complete pathologic response, there was no benefit for post-mastectomy radiation. And when they specifically looked at those with ER/PR negative disease, there was in fact improvement of overall survival with the addition of radiotherapy, with a hazard ratio of 0.65 and a significant p-value of less than 0.01. Now, do we have any randomized evidence? So far, there's none that is completed and published. There are 2 ongoing phase 3 studies, the NSABP-B15 and the Alliance A011202, that are investigating the role of adjuvant radiation in YP N0 and YP N+ patients respectively. The results of these trials will help clarify if adjuvant radiation can be safely omitted in these subsets of patients after neoadjuvant chemo. So on the right side, you see the diagrams of both of these studies. And the first one, they include patients with T1, T3, and N1. All patients will receive neoadjuvant chemo. And eventually, those who have a complete response in the lymph nodes will be randomized to either no regional radiotherapy, only radiation to the breast will be allowed if breast conserving surgery was done. Patients will be, the second arm will be treated with regional nodal radiation. In the second arm, it also included patients with T1 and T3 and N1 and N0 breast cancer that also received neoadjuvant chemo. And those who will have a positive sentinel lymph node biopsy, they will be randomized to either completion dissection followed by radiation therapy, or to no axillary lymph node dissection, but only radiation therapy to the chest wall or breast with the regional lymphatics. In conclusion, most patients with breast cancer who require neoadjuvant chemotherapy will eventually need adjuvant radiation. After breast conserving surgery, radiotherapy is always delivered to the breast, plus or minus regional lymph nodes, even in the presence of complete pathologic response. After mastectomy, the need of post-mastectomy radiation needs to be individualized and is indicated in the following. It's almost always given for advanced stage disease, T3, T4, and 1 and 3. It is also indicated in the presence of residual nodal disease. Post-mastectomy radiation can be omitted in select patients with stage 2 disease after complete pathologic response in the absence of high-risk factors, as mentioned earlier, like ER/PR negative disease, young age, etc. And finally, ongoing phase 3 studies will better define the role of adjuvant radiation for patients receiving neoadjuvant chemotherapy. And I thank you for your attention.
Thank you, Bassem, for the sharp and very clear presentation. So now we move on to the panel discussion with our colleagues, Dr. Fawzi Abu Hijli, radiotherapist at King Hussein Cancer Center, Jordan, Dr. Ziad Ma'arawi, radiotherapist, head of gynecology department at Al Bayruni University Hospital, Syria, and Dr. Najib Jahshan, an old friend of me and a younger friend of myself and my dad, oncologic surgeon at Hôtel Dieu de France University Hospital, Lebanon. So we begin the panel discussion.
Thank you, Dr. Ali. Should we go first with answering the questions from the
Probably,
attendees?
Yes.
Okay, so first question was from Manal Biglawi. How accurate can MR be used after adjuvant radiation therapy? I think this is meant to be for Dr. Kanj.
So actually, concerning the accuracy, it was presented in a large series comparing 6 studies. And according to that, there was a positive predictive value of MRI, which is defined as ability to correctly predict the presence of residual disease at final pathological examination was something like 93%, which is excellent. However, there was limitation concerning the negative predictive value, which is defined as ability to correctly predict the absence of disease at final pathological examination, which was moderate, something like 65%. And this actually was the limitation. And according to comparing, as we said at the end, the combined therapy, we see that at the end of treatment, MRI is more accurate than PET-CT. And during the neoadjuvant chemotherapy, PET-CT is more accurate than MRI in assessing tumor response.
Thank you, Dr. Kanj. The second question regarding the whether the hormonal therapy would affect the MR sensitivity during or after completion of hormonal therapy in both ways in the settings of follow-up after completion of treatment.
Concerning actually the accuracy of MRI related, there was different factor affecting the accuracy of MRI in predicting the response. Of this was the type of treatment. The most important findings were associated with taxane and anti-angiogenic drugs, because we know that affect the neoangiogenesis or the DCE pattern of enhancement of the lesion, which could actually overestimate the response on MRI. However, I don't have experience on how hormonal therapy could influence actually the specificity by itself.
Thank you. I'm just going to leave the floor for my colleagues, Dr. Ziad and Dr. Najib, if you want.
Dr. Najib, we are not hearing you. I think you need to activate your the microphone.
Dr. Najib, we cannot hear you. Unmute yourself, please.
Bottom left.
Yes, it's better now?
Yes.
Yes. So we have a third question addressed to Dr. Youssef, I think, from Manal Deglawi. She is asking, how would the presence of lymphovascular invasion affect post-surgery adjuvant radiation in stage 1? Stage 1.
Stage 1.
Yes, she's asking about stage 1, which is not, normally they don't receive neoadjuvant treatment.
It is true, like we almost never encounter a patient with stage 1 who receives neoadjuvant chemo. So I cannot figure out if there's a specific scenario that you would like to ask.
You may ask perhaps, you may answer perhaps about stage 2 and stage 3, about
like
lymphovascular
invasion by itself is one of the risk factors for recurrence, but we do not use it solely to decide on the need of adjuvant radiotherapy or not. So if that's the only risk factor, so let's give a clear example. Let's say a patient has stage 2 breast cancer. She received neoadjuvant chemotherapy and she had a complete pathologic response. If she has lymphovascular invasion, by itself, this will not be an indication for adjuvant radiotherapy. I mentioned other risk factors that were proven to increase the risk of local regional recurrence, including ER/PR negative disease, young age for the patients, but LVI by itself will not require the addition of radiotherapy.
Fine, thank you. Thank you. We don't have other questions, but I'm going to ask a question as a surgeon. My question will be addressed to Dr. Kanj. As surgeons, when our patient receives neoadjuvant chemotherapy, we have the risk of disappearing of complete pathological response or complete radiological imaging response. What do you do in previous to neoadjuvant treatment? What do you do to localize the tumor? And what is the method, the best method to localize the tumor before neoadjuvant chemotherapy?
Actually, thank you for the question, Professor Jashan. And it should be before and after. The idea is to put the marker within the lesion at the time of diagnosis. The best practice is during biopsy, always put a marker. I know it's something is not covered by all third parties and the medical insurances, but the good practice is always to put a marker, MR compatible marker within the lesion, especially for large lesions or advanced disease. And this actually would for sure facilitate the identification of the complete response and the site of the primary lesion. So the tumor marker is the best method accepted. Under echography or under MRI, both are accepted and admitted. It depends on the lesion type, if we are dealing with mass-like lesion or non-mass-like lesion to follow it.
Okay, thank you very much. There is another surgical problem, which is the fragmentation of the tumor. Can the MRI give a suitable answer about the fragmentation of the tumor? Because if we think of a possible conservative surgery, we need to obtain negative limits. And if there is a fragmentation of the tumor, this is a major problem. Can MRI or ultrasound or mammography give a good answer about the fragmentation of the tumor, and what is the accuracy about this point?
Actually, Dr. Jashan, this is the debate of current practice, of our current practice, and limitation of our present technology. We know that fragmentation or type of response of tumor to neoadjuvant chemotherapy, the pattern of response And sometimes with the fragmentation, we could underestimate the exact burden of the persistent lesion, or sometimes overestimate if we have associated inflammatory reaction. And this would limit the accuracy. This is why the question was the direction toward functional imaging and molecular imaging and quantitative imaging. And I think maybe diffusion-weighted imaging would help by ADC value, by the measurement of restriction degree of residual lesion. But even with ADC, there are technical limitations due to the artifact sensitivity of these modalities. They are very sensitive to artifact, which could limit also the sensitivity. Also for spectroscopy, it would help, but there are limitations. So there are several techniques on modalities under investigation to reach actually the point where imaging could actually confirm the complete response with accuracy, unfortunately. But comparing the other modalities, still MRI, the most sensitive imaging modality with all limitations.
Thank you, Dr. Kench.
Thank you.
So maybe we need to move on with the next session about risk of subsequent primary cancers among breast cancer survivors according to HR status. So the presentation will be held by Dr. Youssef Bensouda from Morocco. He's a medical oncologist at Margel Oncology Center au Maroc. Donc, bienvenue à vous, chers collègues. Dr. Bensouda, nous vous écoutons.
Bonjour tout le monde. Je suis désolé, je vais présenter en français. Je pense que le message passera mieux. Voilà, je suis ravi d'être parmi vous avec mes chers professeurs Fadi Farhat et Samir Khatib, que je remercie pour leur invitation, ainsi que ma collègue Dr. Hassani Kautar. Donc, on m'a confié un sujet assez original sur lequel j'ai pris quelques jours pour voir un peu. Ce n'est pas habituel de communiquer sur ça, mais c'est un sujet important et on va discuter ensemble du risque de survenue d'un deuxième cancer primitif chez des patientes qui sont suivies pour un cancer du sein. Donc, cela va être basé sur des données américaines, donc les données de registre américaines. C'est celles qui sont le plus adaptées à discuter ce sujet, notamment quel est le risque en fonction du statut des récepteurs hormonaux au départ. Alors, tout d'abord, avant de passer et de parler de cela, il faut définir c'est quoi un second cancer primitif. Ça paraît simple, mais en fait, il ne faut pas rentrer dans des détails, il ne faut pas mettre dans ce sac tout. Donc, on va enlever tout ce qui est récidive locale. Ce n'est pas un second cancer. Et bien sûr, on va enlever tout ce qui est métastase. Donc, le second cancer primitif sera une nouvelle tumeur primitive infiltrante qui sera diagnostiquée chez un patient, un individu qui a déjà un cancer et que ça ne sera pas une récidive, ni une métastase, ni un cancer multifocal ou multicentrique. Voilà, une fois qu'on a défini comme il le faut le second cancer primitif, on va estimer la survenue de ce risque. Alors, si on prend les données US, on estime qu'à peu près 20 millions de patients seront des survivants par rapport au cancer du sein. Alors, on ne parle pas de longs survivants, on parle juste de survivants, ça veut dire des patientes qui ont été traitées par un cancer du sein et qui sont toujours donc en survie. Alors, quel est le délai qu'on retient entre le cancer primitif et la survenue d'un second cancer? Le délai qui a été retenu dans la plupart des études est de 1 an. C'est-à-dire qu'on va éliminer tous les cancers qui sont synchrones et on prendra que les cancers métachrones. Donc, il faut que le cancer intervienne dans un délai d'au moins 1 an, c'est ce qui est retenu par la plupart des études, entre la tumeur initiale et le deuxième cancer. Alors, lorsqu'on prend ce risque de second cancer en fonction du cancer initial, on va voir que pour le sein, cela paraît facile, le cancer du sein comme second cancer étant le plus fréquent, c'est ce qu'on voit ici. Donc, nous, ce qui nous intéresse aujourd'hui, c'est de parler des seconds cancers par rapport à un primitif sein. Alors, quels sont ces seconds cancers? Là, c'est à peu près les plus fréquents. Ils ne sont pas classés par ordre. Donc, le plus fréquent, c'est d'avoir un deuxième cancer du sein. Ensuite, on aura donc comme fréquence, comme d'autres possibilités, des cancers ORL, des cancers de l'estomac, œsophage, des cancers du côlon, cancer de l'ovaire, les sarcomes, les mélanomes et puis les leucémies aiguës. On va voir ensuite tout cela ensemble. Quelle est la fréquence? en fonction des statuts des récepteurs hormonaux de chacun de ces types de cancers. Alors ça, c'est toujours pour le risque. Quel est et comment peut-on estimer ce risque de survenue? Alors le risque, il est à peu près de 20%. Ça veut dire une patiente qui est déjà suivie par un cancer du sein, elle va avoir un risque d'avoir un deuxième cancer du sein d'à peu près 20% de survenue d'un second cancer qui sera le sein, qui est un des plus fréquents. Et on estime à peu près entre 15 et 20% des patientes qui sont déjà suivies par un cancer du sein vont finir par développer un second cancer, que ce soit un cancer du sein ou un deuxième cancer primitif. Alors, l'âge intervient dans cette fréquence parce qu'on va voir que plus la patiente est jeune au diagnostic, plus ce risque est important parce qu'il y a un long follow-up et du coup, il y a un intervalle beaucoup plus important de risque d'avoir un deuxième cancer. C'est ce qu'on voit ici. Ce risque, il passe de 6 à 3 à peu près et il descend jusqu'à 1 pour les patientes qui sont âgées. Donc, l'âge intervient de manière assez importante pour ce risque de faire un deuxième cancer et ce risque il passe pour les patientes qui sont jeunes à peu près les patientes de moins de 40 ans à 3 fois plus au lieu de 1,18 comme risque relatif. Ensuite, si on prend toutes les patients qui ont déjà fait un cancer, quel est le risque d'avoir un cancer du sein qui est plus fréquent? Ce cancer, selon cette database toujours américaine, on est à peu près à 4% entre femmes et hommes pour faire un cancer du sein, quel que soit le primitif. Alors, une fois qu'on a parlé de tout ça, il faut se poser la question, pourquoi nous allons faire un deuxième cancer primitif? Pour quelles raisons, en fait? Donc, il y a plusieurs explications, il y a plusieurs prédispositions aux facteurs de risque en fonction du cancer pour lequel la patiente est traitée. Donc là, il s'agit du sein. Et donc, le risque le plus important, c'est d'avoir une mutation. Donc ça, vous le savez, je ne vais rien vous rajouter. Lorsqu'on a une mutation des gènes BRCA1, BRCA2, le risque sur 10 ans d'avoir un cancer du sein contralatéral, donc on est sur un second cancer, est de 27% pour le BRCA1, 32% pour le BRCA2, versus simplement 8% pour les patientes qui n'ont pas de mutation. Donc ce risque est multiplié par 3. Si on prend ensuite le cancer de l'ovaire, là aussi il est relié au risque d'avoir la mutation BRCA1, BRCA2 et 10% des patientes qui vont faire un cancer de l'ovaire auront cette mutation. Donc voilà, ça explique déjà pourquoi on fait un second cancer, mais ça n'explique pas tout, ça explique juste une partie de ces seconds cancers. La deuxième explication, donc la radiothérapie, on parle de la radiothérapie qui est ancienne, avant les années 80, où le risque était présent d'avoir des deuxièmes cancers. On demandera l'avis de nos experts ici présents par rapport au risque actuel de faire un deuxième cancer primitif relié à la radiothérapie. Des données qui ont été un peu retrouvées sur la database américaine à la fin, donc entre 1973 et 2002, rapportent à peu près 5% de risque après un cancer du sein irradié. Alors, il faut pas, lorsqu'on parle de radiothérapie, on va parler aussi de tabagisme parce que lorsqu'on combine les deux, ce risque est augmenté. Vous le savez, pour le cancer du poumon, le fait de ne pas arrêter le tabac, il y a un risque de progression. Pour le sein aussi, le fait d'être irradié et d'avoir fumé, cela donne un double effet et on a plus de risque de faire un cancer du sein contralatéral du même côté que la patiente qui a été traitée au niveau de la radiothérapie contralatérale. Alors, lorsqu'on combine à la fois une femme fumeuse et qui n'a pas été traitée par la radiothérapie, ce risque est multiplié par 6. Mais lorsqu'on combine la radiothérapie et le tabagisme chronique, ce risque augmente à 9. Donc, patiente irradiée avec tabagisme, on a beaucoup plus de risque d'avoir un second cancer. On arrive au tamoxifène. Là, la balance elle est plus pour le bénéfice que le risque. Bénéfice sur le risque de survenue d'un second cancer, donc ce risque est diminué. Donc, c'est un effet préventif. Par contre, le risque d'un cancer d'endomètre, il est multiplié par 2 ou 3 en fonction de la durée. Et là, ce risque est vraiment nettement abaissé parce qu'on sait mieux dépister nos patientes, on sait les surveiller et on fait des échos endovaginales pour voir l'endomètre chaque 6 mois pour surveiller. Alors, on arrive à un autre facteur de risque qui est l'obésité. Vous le savez, le poids est lié au cancer, que ce soit à la survenue de cancer ou au risque de rechute d'un cancer. Donc, par rapport au sein, cela est connu, le risque il est de 37% majoré. Et puis, il y a d'autres cancers qui sont liés à l'obésité, notamment celui de l'endomètre et le cancer colorectal. La chimiothérapie, elle aussi, peut expliquer la survenue de ces seconds cancers, notamment les agents alkylants, et puis les inhibiteurs de la topoisomérase. Le risque de second cancer apparaît plus pour les leucémies myéloïdes aiguës, avec un risque multiplié par 2. Alors, on arrive à un article que m'a partagé le professeur Fadi Farhat pour discuter avec vous le risque en fonction du statut RH, parce qu'il n'y a pas beaucoup de données. C'est des choses qui émergent. On va discuter, on va voir tout cela ensemble rapidement. Alors, ce n'est pas des études randomisées, c'est toujours des databases qui montrent à peu près le risque de 17% de faire un second cancer chez une population qui a été suivie et qui a fait un second cancer primitif. Et puis, on a essayé de voir quels sont ces seconds cancers et quel est ce risque par rapport au statut RH. Alors, on a pris des patients entre 20 et 84 ans qui étaient voilà, sur une période de 1992 à 2015, un suivi quand même assez long d'à peu près 20 ans. Et puis, le délai qui a été retenu entre le primitif et le deuxième cancer primitif, c'est 1 an. Alors, on avait à peu près 431 000 patientes avec le statut RH. Et puis, la database n'avait pas le statut HR2 que vers 2012 à peu près. On a inclus des patientes avec les deux. Donc là, je vais parler surtout des données en fonction des RH. Donc, on a plus de RH positifs et un peu de RH négatifs, comme vous le savez. Donc, c'est normal, à peu près 80% de RH positifs. Alors, on arrive à la conclusion. Les patientes avec cancer du sein RH+, ont un risque élevé de 20% de faire un deuxième cancer primitif. Et celles avec un cancer du sein RH négatif auront 2 fois plus de risques. Donc, ce risque est majoré à 40% de faire un deuxième cancer primitif. Et puis, en comparant les deux sous-groupes, le P était significatif. Donc, la conclusion de cette database, c'est de dire que lorsqu'on est RH négatif, on a plus de chances, pas de chance, mais plus de risques de faire un cancer, un deuxième cancer primitif. Alors, quels sont ces cancers? Voilà, donc c'est le sein qui est le plus fréquent, un peu plus pour les patients RH négatifs que les patients RH+. Après, il y a le cancer du poumon, les cancers utérins et les cancers coliques. Et puis, on est parti chercher même chez la population RH négative pour voir quels sont les sous-types les plus fréquents. Donc, il y a des cancers qui sont plus fréquents chez la population traitée par un cancer du sein RH négatif, notamment les leucémies aiguës, les cancers péritonéaux, les cancers du sein, comme on l'a vu, les cancers ovariens et les cancers du poumon. Donc, ce type de cancer arrive plus chez les patientes RH négatives. Et puis, les cancers thyroïdiens sont beaucoup plus fréquents chez les patients traités par un RH positif. Là, c'est juste des tableaux de l'article pour vous montrer le type de cancer. Ça, c'est en fonction de l'âge. Il y avait une petite différence en fonction du spectre de cancer primitif chez les patients jeunes par rapport aux patients âgés. Chez les patients jeunes, il y a plus de leucémie aiguë, de cancer du sein, sarcome, cancer ORL. Les patients au-delà de 50 ans, on avait plus de leucémie aussi chez les deux, de sarcome, de thyroïde, de sein. Alors, on arrive au sous-groupe. Là, c'est plutôt pas le risque relatif, mais c'est un calcul de risque absolu par rapport à 10 000 personnes par an. Et on arrive à voir que le sous-groupe de patientes qui sont à la fois jeunes, 20-49 ans, avec des RH négatifs, feront plus de cancer du sein et feront plus de second cancer primitif. En majorité, c'est le cancer du sein, mais même les autres sont majorés. Du coup, que peut-on retenir de ces nouvelles données de la database? C'est que le risque de second cancer primitif est beaucoup plus élevé chez la population RH négative par rapport à celle positive. Ce risque est majoré chez la population RH négative parce qu'on a plus de leucémie aiguë, plus de cancer du sein, plus de cancer de l'ovaire, cancer du péritoine et cancer pulmonaire. Pourquoi les RH négatifs sont plus à risque? Peut-être qu'il y a la prédisposition génétique, notamment on sait très bien que les triples négatifs sont des patientes qui sont plus souvent mutées, donc plus de seins, plus d'ovaires. Les traitements reçus, donc c'est des patientes qui sont plus traitées par chimio, par radiothérapie que les populations RH+. Et puis on sait que les patientes RH négatives sont beaucoup plus agressives, il y a beaucoup plus de mutations. Donc ça peut expliquer à peu près ce risque plus élevé. Et puis la jeune aussi est corrélée au RH négatif. Donc, on a plus de risque de faire un second cancer lorsqu'on est jeune. Alors, quel est le corollaire de tout ça? Est-ce qu'on doit faire un screening plus poussé de second cancer? Voilà, on voit nos patientes un peu en surveillance. On cherche surtout la tolérance de l'hormonothérapie lorsqu'elles sont RH+. On essaie de guetter un peu la récidive. On essaie de faire les mammos annuelles. Certains centres font le CA15-3, d'autres ne le font pas. Et puis, on oublie les seconds cancers. Donc, est-ce qu'il faut faire un screening plus poussé, notamment pour cette sous-population de jeunes patientes RH négatifs? En tout cas, les recommandations, là, je vous ai mis, c'est de la NCCN. Je pense que chacun a sa recommandation. Ça reste un peu classique. On agit un peu sur le facteur génétique, on cherche en la mutation lorsqu'il y a le risque. Donc là, ça peut jouer pour détecter de manière plus précoce ce second cancer. On agit sur la mammographie annuelle. Et puis, on agit sur l'hygiène de vie, donc notamment avec le poids, donc c'est de recommandation, l'activité physique. Là aussi, ça peut réduire le risque de second cancer. Et puis, on demande aux patients de venir et d'être là pour les consultations de surveillance parce que c'est très important. Voilà, je vous remercie et j'espère avoir été un peu clair par rapport à ce sujet. Merci.
Merci, Dr. Bensouda. Ce fut très clair et très intéressant surtout. On va passer so we're going to talk now about the advances in HR positive, HER2 negative advanced breast cancer with Professor Fadi Farhat. Hello, Fadi. I'm happy to see you, and you can begin, please. So, Fadi, we're not seeing you and not hearing you neither. Fadi, maybe we're having some technical issues.
Oui.
Ah, Fadi, tu nous entends?
Oui, je suis là. Oui, oui, je vous écoute.
Ok, on n'arrive pas à te voir.
Oui.
Ok, ça commence,
Voilà.
parfait.
Est-ce que vous voyez?
Oui, oui, yes.
Voilà. Ok, voilà, donc on va commencer. Donc, merci pour votre présence. Je suis très ravi. I'll speak in English. So, hello everyone, and thank you for being with us today in the ABC. I would like to thank Dr. Sam Al-Khatib, the president of the AMAC. I would like to thank all the audience. I would like to thank Dr. Ali Shamsuddin, the sharing the session, and all panelists. So today I will be talking about, you can see my screen, yeah? About the advances in hormone receptor positive HER2 negative metastatic breast cancer. We know very well that
please share your lecture.
We are not seeing your screen. Can you please share your presentation?
Okay, yes, I will. Let's try again. So share screen.
Okay.
Now, do you see it?
Yes.
Okay. I'm sorry. علي مبين السكرين عندي ولا لا؟
Yes, بس بدك تعمل agrandissement من تحت على اليمين.
I'm trying. ما عم تمشي معي بس اكبس عليها. بس اكبس عليها. Let me check the last time. Yeah, I see the problem. يلا.
مش مشكل.
Okay.
Yes, perfect.
So defining the molecular interaction between estrogen between estrogen and growth factor receptor signaling that will lead to tumor progression is essential to understand how to target this critical pathways in breast cancer. So hormonal therapy was first used more than 100 years ago, you know very well. The principle was based on blocking the estrogen receptor activities. And it was Bitson who first has the idea to block the estrogen receptor by doing the castration. And the classical mechanism of hormone action involves estrogen binding to estrogen receptor, as you know, in the nucleus, but not also even outside the nucleus. And this will promote the association with the specific estrogen response. However, the estrogen receptor also regulates the expression of many genes without direct binding, like, for example, the activator protein, as you can see here, activate protein. So as you can see, the estrogen can act intranucleus and extra. Now the interaction, the major problem in breast cancer management is the conversion from E-sensitive to E-resistant disease after starting on estrogen therapy. And we know very well we started with the castration or with the estrogen therapy. Then after we observed the shift from sensitivity to resistant, and this was probably the emergence of this independence from estrogen was due in part to the interaction, the enhanced interaction between the growth factor receptor that you can see here and ER during the progression of the disease. This independently of the estrogen stimulation. And we have to understand that tumor cells may also circumvent pharmacological blockage of estrogen response by enhanced expression of aromatase. And we know very well this was the reason how the aromatase inhibitors was developed. And the high expression of aromatase will increase the estrogen biosynthesis, and the aromatase induction occurs in HER2 overexpression and in those with active crosstalk between estrogen receptors and growth factor mediating signaling pathways. So not only the estrogen, but also the aromatase inhibitor will lead to high expression of estrogen. And as I told you, it will be stimulating the intrinsic, the intranucleus and the extranucleus receptors. And also we have to remember the interaction between the growth factor and the estrogen receptor during that. And it was known from a long time that the estrogen deprivation will mimic the low estrogen levels produced by aromatase inhibition, which will lead to an adaptive changes in cell behavior. And this will lead to the hypersensitivity to estrogen. So even small doses will lead to stimulation and the increased aromatase activities. Also, in addition, interaction with different growth factor receptors like this one, the EGFR, HER2, and EGFR. And together, the stimulation by much smaller amount of estrogen will negate the benefit of treatment with aromatase inhibitor. So this complex modulation of estrogen sensitivity by tumors may support the use of sequential endocrine therapy with agents having different mechanism of action. And that's really what we are doing now in the ER-dependent breast cancer tumor. We are using no more chemotherapy. We are trying to do a sequential endocrine therapy using first line, second, and third line. And also, however, based on the notion that multiple signaling pathways activate the ER estrogen receptor, combining therapies with both endocrine and non-endocrine agents that block different pathways, as you can understand, different pathways should be blocked, has a rationale, and this is actually in real life in clinic. And there is a potential that the TKIs of the growth factor receptors alone or combined with anti-hormone agent will overcome the endocrine resistance, and that's what happened also in practice. And so the strategies to disrupt the signal transduction by independent signaling pathway is by blocking apoptosis also has been considered, taking in consideration the action on the insulin-like growth factor, SRC, PI3K, ACT, and mTOR. So this is an introduction to start talking about how things emerged and developed in the few past 3 years. We understand well that there has been a clinical trial programs, first on the estrogen receptor by doing anti-estrogen or downregulating the estrogen, the aromatase inhibition with different molecules, steroidal or not steroidal. Then by inhibition, the mTOR pathway, as you can see, the estrogen or the aromatase inhibition, and then after inhibition, the mTOR, which is in the central of an important pathway, and then after to work on CDK, which is also central, and then after trying to block in a higher level the PI3K. And don't forget that there is also that now ACT inhibition and others. So this is how the clinical program of studies was mentioned. Now, I wanted to see what was the participation of different companies in this pathway, and I took this schema and looked to the, for example, AstraZeneca program, which you know AstraZeneca is very hormone oriented, and we see that they developed the anti-estrogen, which was the Nolvadex, then after the down-regulated fulvestrant, and then after they work on the aromatase inhibitor. Now they have something coming, maybe the ACT inhibitor, but it's not yet here. And the Pfizer program also worked on aromatase inhibition and CDK inhibition. And you look to Eli Lilly, they worked only on the CDK inhibition. And you look to Novartis, and remember that we are sponsored as ABC by Novartis, but this represents my personal opinion, what I'm telling you here. So you look that Novartis worked on all others, on all pathways, so starting from inhibition of the aromatase, then after mTOR, then after the CDK, and the PI3K. And this is the volume of the participation or of the program, of the contribution of different. The idea is not to make a marketing, but personally, I worked on all these trials, the mTOR inhibition, the CDK4/6 with Mona Lisa 2 and 7, and the SOLAR trial, the BELL trial, and not the BY-LEAF. So that's why I'm interested to talk about this topic. And if I go back to the participation of this program, we can say that the mTOR inhibition, it was the Bolero-2 in which also we participated, aimed to inhibit the mTOR pathway, the PI3K, the PI3K pathway, which PI3K ACT mTOR pathway by inhibition of the central mTOR. So, indeed, the first inhibitors was the PI3K inhibitor, the everolimus. Remember that everolimus as monotherapy will not be efficacious, but it's only good to overcome the resistance to estrogen receptor. So remember what we said previously, that the growth factor receptor might overcome the sensitivity of estrogen, but the mTOR inhibitors, mTOR, which does not work alone, will rescue the sensitivity to the of the estrogen receptor, and that's why in combination it will be helpful. Now, then after the companies and Novartis specifically worked on different on ribociclib, which is a CDK4/6 inhibitors, with 3 trials, Mona Lisa 2, 3, and 7, and with a complement trial, complement 1, which was a real life data. And the idea here was to block the CDK4/6, which you know very well the action. I will not go through that. And remember, look to the program. It was a huge program, Mona Lisa 2, 3, 7, and the complement 1, which is phase 3B, and different indication. Prior endocrine therapy was accepted in the Mona Lisa 2, which means second line. Then after prior endocrine therapy for the Mona Lisa 3, for the 7, it had the character to be only for premenopausal patients, and the complement included all type of patients. So postmenopausal, premenopausal, and man and postmenopausal women, all type of patients included in this trial, and the huge number of patients included, almost 60, 650, 750, 650 in all trials, and the 3,000 in the 2 trials. And not only the Mona Lisa trials were here, but also the Paloma program with Paloma 2, 3, and the Monarch 2 and Monarch 3 were here. But we can look that the trials that showed us overall survival benefit were only 3. The Monarch 3 for the abemaciclib and the Mona Lisa 7 and Monarch 3 for the ribociclib, which is excellent, showing that we have 2 trials showing the advantage of ribociclib in premenopausal and in postmenopausal. And if I look to the program of Novartis with Mona Lisa 2, 3, and 7, and there has been a publication taking all these trials and in pooled analysis, they showed that the PFS was really significant, and you can see the difference in progression-free survival, and it's well seen in both arms, 25 month versus 15 month. And there is no overall survival yet data because the Mona Lisa 2 trial has not yet published the data on overall survival. It's not yet closed. And the complement trial also, which include, as you can see, different type of patients and also with CNS metastasis, and it took the same as the Mona Lisa program, ribociclib plus another hormone, and it was here letrozole. They showed also a time to progression of 27, which corresponds also, and PFS 26.7, which goes with the phase 3 trial of Mona Lisa. And if I look only to the Mona Lisa 3 and Mona Lisa 7 that took the first and second line treatment with no prior endocrine therapy or 1 line of chemotherapy or more than or 1 line of therapy, if we do a pool analysis, we can see that these patients received or fulvestrant or tamoxifen or non-steroidal aromatase inhibitor. I mean, any combination. We can see that there was a 30% reduction in risk of death in both studies, which is very nice, which goes correspondent to what we have seen. So we have, I will go back, we have a 30% reduction of death in both 0.7 and 0.7 also in the second one. And we have a benefit in any visceral M1 in both trials. As you can see, it's well seen in both figures. And even for liver metastasis, we can see that there is a very nice difference and a good reduction of the risk, relative reduction for the death is 37 and 47. And also we can see that even in endocrine endocrine therapy resistance, we both trials showed a benefit in reduction of the death, 30% and 40%. And remember, if you go back, you look on all trials, we can see that it's higher benefit in the Mona Lisa 7, which probably shows what has been earlier said, that the premenopausal patients are different than the postmenopausal patients physiologically and pathophysiologically. And when we look to the benefit in cases of reduction, we observe that also there's still, even in case of reduction, there's a benefit. And this is important to know because when we reduce the dose, to know that we still have the benefit. So now we go to the update in the SABC San Antonio 2020, and we can see here that there was still a significant reduction in risk of death for the Mona Lisa 7, and the median overall survival is 59 months approximately, which is the longest reported in the luminal AB advanced breast cancer. So this is the update in 2020, and ESMO breast cancer 2021. We have also the results by age subgroup. And also, again, I think it's nice to see these figures. you can see that there is still a benefits at 4 years when comparing the combo ribo endocrine therapy to endocrine therapy alone, 61 versus 48. For those who are more than 40 years, it means the oldest patient in the premenopausal. When you take the youngest patients, and you know very well that it was reported in the Maghreb and in the Eastern region, in the Middle East, that we have youngest patient, you can see that the difference between the combo, its red arm, to the monotherapy is really high, substantially high. It's 35% reduction of death. This again will mean that the premenopausal patients are really different. And this means again that no need for chemotherapy. Look how targeted therapy, look how the CDK4/6 inhibitors, ribo, plus the endocrine therapy is doing a great benefit for these patients. And also the update in ASCO 2021, we can see that at 5 years also we see again and again a nice separation, and relatively, in my opinion, it's higher. The difference is higher than previously. This will make us feel more comfortable with the data of MONALEESA 3 and 7. And you look the overall survival for MONALEESA 3 in first line, we can see also there is a benefit. I will not stop a long time. So in first line or in second line, you have a nice benefit of the combo ribo plus endocrine therapy combo to endocrine therapy. And for those who are blue style, who would like to go in more deeper in the definition of the benefit, you can look that the benefit by MONALEESA 3 and 7 in overall survival as per ASCO threshold is really evident in the 7 MONALEESA 3, and it's also evident in the MONARCH 2, but not really in the Paloma 3 trial. So look at the substantial benefit. This is the threshold accepted by the ASCO, and the ABEMA is good, and the ribo is good, and the ribo again is good, and also we can say very good. So this is what we have. And for those who like the ESMO magnitude of clinical benefit scores, also which reflect the efficacy of the treatment, efficiency of the treatment, you know that ribociclib in the MONALEESA 7 had the score, the highest score, and the only one having score 5, while the MONALEESA 3 had score 4 as others, Paloma and Monarch, and score 3 for MONALEESA 2, because the data is not yet here. We don't have yet the overall survival. I think that is the reason. So finally, I will go through the PI3K if I have a few minutes. I would like to show that also in the PI3K pathway, you can see that Novartis had really a lot of work, and they worked on the PI3K pan inhibition, and then they worked on the PI3K alpha inhibition, and they worked also on the PI3K after CDK inhibition. And it's important because also they tried to target the central, the PI3K ACT mTOR pathway. The BEL-2 trial showed a benefit, but an advantage by giving the buparlizib, but unfortunately, it was very toxic. So the real clinical benefit was not here. And for those who participated, we participated, there was a lot of diabetes and controlled diabetes. So the drug was classified, was not used. Then after we go to the SOLA-1, which you know very well, and which study the concept, the proof concept. So you can see that they took the PI3K mutant or PIK3CA mutant or not mutant, and they give alpelisib plus endocrine therapy versus endocrine therapy in the both arm. And the primary endpoint was the PFS in the PIK3CA mutate. So the idea here, why we say proof of concept, because to say that really if there is any mutation, does the alpelisib overcome the resistance to the endocrine therapy? And we can see that the data was here with the PFS, And we can, as you can see, a big difference in the PFS 11, 5.6, almost doubling, 35% reduction in death. And also we can see that the overall survival was not significant. And here we know that Andre, I forgot his name in Institut Gustave Roussy, Andre was not very glad for the rejection of the approval of alpelisib. But when you look to the lung and liver metastasis, please look at the benefit on the overall survival, 37 compared to 23 months. So really an important advantage in overall survival benefit when you give alpelisib in some type of disease, the visceral disease, the lung and liver metastasis. And I will not go through the toxicity. It's not my job today, but I would like to talk about the BILIEVE, because in the trial of SOLAR-1, we had a small, very, very small number of patients who received the CDK inhibitors, and now the CDK moved to the first line. So what to do after? We know that the rationale for the BILIEVE that was that patient who received the CDK inhibitors and received after the alpelisib, 9 patients only compared to 11 who received only endocrine therapy, showed a substantial benefit of alpelisib plus endocrine therapy, as you can see here. So this was the rationale to start the BILIEVE trial, where there was a 3-cohort patient who received CDK-I with aromatase inhibitor, cohort B with fulvestrant immediately before the alpelisib, and then after the cohort patients who progressed on after aromatase inhibitor and received chemotherapy. So the aim here was to see how patients will respond to the alpelisib plus fulvestrant or plus aromatase inhibitor if they have received in first line alpelisib plus any endocrine therapy, and also those who received the chemotherapy. And here we are analyzing only the arm A and B, and we can see that the patient who received the fulvestrant, alpelisib with fulvestrant after CDK aromatase inhibitor had 7.3 months PFS, which is really acceptable, which is good in such line. And those who received the aromatase inhibitor plus the alpelisib after CDK plus fulvestrant had a 4.7 month of overall of PFS. And the update of this trial in ASCO 2021 is here showing that the median time for progression was 7.3 for all patients and 5.7 for all patients for those receiving fulvestrant or aromatase inhibitor. And the conclusion was that there was no significant difference in PFS between high and low subgroups, and the analysis of proportion of patients alive without PDK at 6 months versus duration of prior CDK 6-1 showed that this is important, that there was no difference in PFS for those who received the CDK for a short period or for a long period. This is the meaning of this analysis. Little evidence that duration of prior CDK4/6 inhibition impact efficacy in either arms. Remember, this means if your patient progressed rapidly on CDK, which is the case in some of our patients, and if there is any mutation of the PIK3CA, alpelisib is still efficacious. And if the patients responded for 3 years, also alpelisib is efficacious. And the take-home message from my side is that understanding. So the message is here that our understanding of the mechanism of estrogen actions and the biological basis of resistance of endocrine therapy is advancing rapidly. We understand well these interaction between estrogen receptors and the growth factor receptor, and the interaction and the action on intranuclear and extranuclear estrogen receptors. Multiple routes, it's now clear that there are multiple routes by which ER-mediated pathways may be activated and that the tumor will tumors will use adaptive mechanism for sustained growth after initiation of endocrine therapy, understanding the endocrine resistant, the aromatase inhibition, the efficacy of the growth factor stimulation, TKI or others. And the combo, finally, the combination therapy is directed to extranuclear and nuclear estrogen receptor and GF signaling pathway is in the clinic nowadays. Mona Lisa program showed overall survival benefit in all subgroups of patients, premenopausal, postmenopausal, ET resistant, ET sensitive, age less than 40, more than 40. And SOLAR-1 and BY-LEAV confirmed the efficacy of alpelisib in first line and post-CDK in PIK3CA mutated patients. With that, I stop and I will give the floor for Mr. Chairman and the dear panelists. Thank you very much.
Thank you, Professor Farhat, for this great presentation. So we have for the panel discussion today with us Dr. Nidal Jabrini from Medical Oncology at Beit Jala Hospital from Palestine. And I think Dr. Al-Bimani.
Ali, I think unfortunately we don't have any of the panelists.
Okay.
Mainly Dr. Nidal Jabrini just called me and he told me إنه في مظاهرات كثيرة بالخليل بفلسطين ومش قادر يوصل من السيارة لبيته. So if you would like to take the floor.
Yes.
And Dr. Hazem Asi is sick, unfortunately.
Okay.
Salamat Albo.
So Salamat Albo. Fadi, I have, if I have like two remarks or two questions to comment to talk with you about. It's a really interesting subject, the pathway, the multi-pathway therapy in breast cancer. So maybe it's important in any cancer patient under TKE not to forget the interaction with the drugs. And usually we put a lot of our patients under PPI, under esomeprazole and omeprazole. Do you have any experience about like having a patient who is not responding under CDK4 inhibitor and like because he was taking Mopral or esomeprazole, and when you stop, when you do a pharmacokinetics or the monitoring drug therapy, when you do, quand tu doses ton médicament dans le sang, tu vois qu'il a un AUC bas, et une fois que tu arrêtes the omeprazole, you will have a response. So I think we need to not forget about the interaction of the therapy in our patients who are not responding before like saying they are resistant to therapy. Or I don't know what you have to comment about this, if you have any experience.
So the question is, does PPI impact the efficacy of CDK inhibitors? We know very well that the PPI might impact the results of the efficacy of immunotherapy, but I don't have any clue about the interaction with the CDK inhibitors. But I think it's important to try to observe such cases, because indeed we have some patients not responding to CDKI, but without understanding why, while there are luminal A and B. I have no ideas if really there's any interaction.
You know that in some sarcoma patients, we had like a negative trial, and when we looked at the data and we stopped PPI, we had a positive trial later on. So I think it's important, and even though there's no metabolic interaction, but there's a biodisponibility problem with the PPI. And what I have, maybe another comment about any TKE or tout ce qui est CDK4/6 inhibitor, they have a liver metabolism. So with the CYP3A4. And we know that several of our breast cancer patients, they have a high inflammatory syndrome, CRP élevé, which implies a high interleukin-6. And we know that interleukin-6 inhibit CYP3A4. So maybe one of the ideas is when you have a high tumor burden in your patient, maybe try to do a chemo or some attack chemotherapy to reduce the inflammatory system or in reaction. So maybe they will respond better under this kind of therapy, because when you inhibit the liver, you will not maybe have a good response due to high interleukin-6 in the body. Well, I don't know, what do you think about this remark, Fadi?
I repeat again that we don't have any idea about this, but here I see Dr. Yusuf Bensouda is saying that they have some data with capecitabine and omeprazole, but I'm not surprised to have, as you said, since the bioavailability of the drugs will be different when you are taking omeprazole or any PPI. So maybe there is a room to study this interaction. And here I invite Lily.
Yes, je pense qu'il faut qu'ils regardent leurs données et peut-être, je suis quasiment sûr qu'ils auront des différences de réaction. Et pareil qu'avec la CRP, parce que c'est très logique en fait. On sait qu'il y a un métabolisme hépatique qui est dû à CYP3A4. Lorsqu'il est inhibé grâce à l'inflammation, ben, ça peut justement baisser l'efficacité. Et ma dernière remarque, Fadi, do you have any ideas about the influence of the spatiotemporal evolution of this kind of pathway and about the response? Did we do some biomarkers, follow-up biomarkers to see if we can challenge some patient, if we change, s'il y a une évolution spatio-temporelle à fait de ces marqueurs? Est-ce que tu penses qu'on peut rechallenger certains patients ou rattraper d'autres patients qui ont échappé à ce genre de traitement?
Already what you are doing, you are re-challenging. So when the patient is receiving the aromatase inhibitor and you are re-challenging with aromatase inhibitor and CDK, you are overcoming the resistant. So it's a kind of re-challenge. Now, if the question if can we re-challenge the CDK4/6 inhibitors, probably yes, probably in the future we can use it. But nowadays, since you have a different type of endocrine therapy, nobody will go to the re-challenge. The re-challenge was usually used, if we remember well, for example, in the GIST, where they used imatinib, then after sutent, then again imatinib, when they don't have other drugs. But since in hormonal sensitive tumor, we have now the downregulator of estrogen, we have the aromatase inhibitors, we have the CDK, we have the alpelisib, the mTOR inhibitors, and we have the PI3K inhibitors, and now soon we'll have the ACT inhibitors. I think that re-challenging for any of these pathways will be will not be used. But I think that combination of inhibition of different pathways will play a role in the future, because again, when you are blocking a pathway, you are stimulating the higher level. So to give an example, if you give anti-MEK and anti-RAF, the anti-RAF will stimulate the MEK. So the MEK will be active and the tumor will be again and mitosis. So you have to block two different pathways. And probably this will be the future for the breast cancer luminal metastatic disease, by blocking different pathways more than by re-challenging. This is my opinion.
I totally agree with you, but maybe the tricky question about this blocking multi-pathway therapy in cancer, in my opinion, you can have 20 pathways. But if you have them in the same direction, targeting the same problem in the cancer, it's not very smart. But if you can target like 20 pathway and only hit apoptosis. But you can target 3 pathway and hit apoptosis, cell fate, metabolism. So maybe to higher up the reflection about multi-pathway therapy, maybe you need to be a multi-pathway and multi-level therapy, like not to hit the same big general view in the cell, apoptosis, metabolism, etc., etc. I don't know if you see what I mean, Fadi.
Yes, I understand very well. It means it's a very long discussion, but you mean not going only horizontally, but going also vertically.
Yeah, because you can have mutation in the same pathway, you are going to hit apoptosis. But you can have apoptosis, cell fate, metabolism, etc. And this will be more interesting, I think.
Okay, I think it's really nice, but we will maybe we have to move. But I would like to hear, if you don't mind, Dr. Ali, the opinion of our colleagues, Dr. Bensouda, about you said there's data of capecitabine Dr. Lala Kauthar about the absence of interaction, and also I received from Novartis that apparently, I will read it, ribociclib will increase the level or effect of esomeprazole by affecting hepatic intestinal enzyme CYP3A4 metabolism. Minor significance or unknown. So probably we don't have, it's a minor impact. But
généralement, on demande aux patientes d'éviter de prendre beaucoup d'oméprazole parce que même s'il n'y a pas de données très claires qui montrent un sous-groupe où c'est majoré, où le risque d'efficacité diminue, on n'a pas d'études. Mais généralement, on évite et on leur dit de ne pas prendre beaucoup d'oméprazole. Alors, dans la capistabine, ça a été montré, il y a des données qui sont négatives lorsque les patientes prennent beaucoup d'oméprazole avec la capistabine. Il y a Dr Hassani Kauthar parle, je pense, des autres interactions, notamment avec le jus de pamplemousse.
Oui.
Ouais, ça, c'est aussi connu. Voilà, donc, mais peut-être dans le futur, il va y avoir des données plus que ce qu'a dit Novartis, ça veut dire des datas juste de données préliminaires, mais il y aura sûrement des données d'études randomisées.
Excellent. We have many questions in the very nice question in the chat box if you.
So
we have some questions, Dr. Ali, if you would like to take it.
yes, this is what I'm trying to do. So one of the question is, do you think that any of the CDK4 inhibitor is superior over the other in premenopausal women, Dr. Farhat?
So I see the question. Yeah. Okay. We know very well that the only trial including only premenopausal, post-premenopausal patient was the Mona Lisa 7. The Paloma trial included in 20% of patients, which was also stratified from the beginning. They showed that there is a benefit also in premenopausal, but they don't have overall survival benefit. They have PFS only, and this is it might be due to the small sample, 20% only of patients in the Paloma trial. So personally, in premenopausal, I'm really comfortable to use the ribociclib, since we have a trial dedicated for these patients, the CDK4/6, the Mona Lisa 7 trial, in my opinion.
Okay, great. So we have another anonymous question with the shortage of letrozole and in some Arab country, what is your preferred combination, Professor Farhat, with tamoxifen? What do you think if we combine it with CDK4 inhibitor?
Yes. In Arabic we say أذهبي وامطري أينما شئتي فإن ريعك عائد لي. It means that really you can use it with any endocrine therapy. You know very well that also in the Mona Lisa trial, the 7, they used either tamoxifen or aromatase inhibitors plus agonist LH-RH in premenopausal patients. Some will debate that tamoxifen and CDK4/6 ribociclib might make prolongation of QT. We know very well, but we know that also Zofran, which is the ondansetron, can do that. So there is no harm, in my opinion, to use tamoxifen with the CDK4/6 inhibitors, ribo or others. And also we know from the BYLE that patients who received fulvestrant might give more result with the CDK. But remember, giving a combo CDK4/6 inhibitor plus aromatase inhibitor, it's pure oral, no injection. So the response, yes, you can use tamoxifen with the CDK4/6 inhibitor with no risk.
Okay, and maybe one last question. Upon disease progression on top of CDK4 inhibitor, what is your preferred option with negative PK3? Single agent, Abema, or everolimus?
Can I ask the audience here, because the panelist, because I might be somehow biased in this trial, because I participated in Bolero trial, and because I really don't see the toxicity of the everolimus, which everybody is talking about. So, Dr. Bensouda, Dr. Lala, my colleague, Dr. Shamsuddin, what's your drug after CDK inhibition progression?
Je pense que ce qu'on faisait avant l'arrivée des anti-CTK, c'était inhibiteur mTOR avec hormonal thérapie. On n'avait pas d'autre solution. Maintenant, s'il n'y a pas de mutation, qu'il y a progression après anti-CTK, comme tu l'as bien expliqué, on n'a pas de données pour rechallenger un anti-CTK, ni de garder l'anti-CTK et de changer d'hormonaux. Donc voilà, on passera à l'éverolumus avec une nouvelle hormonothérapie, notamment à l'anti-aromatase. Et puis par rapport à la tolérance, donc il faut y aller. Moi, j'y vais doucement, j'y vais à 5 mg avant de passer à 10 parce que voilà, pour voir si la patiente tolère ou pas.
Avec gargarisme?
Oui, bien sûr.
So, Dr. Alala, if you are with us, Dr. Shamsuddin, Dr. Kattan, other colleagues.
Donc, il me semble, c'est une bonne option, l'infinitor, donc évidemment avec un schéma progressif et à petite dose et petit à petit à augmenter en fonction de la tolérance de la patiente et de la réponse de la maladie, en fait. Mais voilà
So,
ce que
I will be great. I will be really happy if any of you is ready to share his data about the use of everolimus, Afinitor, everolimus. Personally, I have a big number of patients receiving everolimus, and I am collecting data to show that in the era after the gargarism, the use of the proactive use of gargarism, we have really less toxicity than previously, and the drug is really well used. The adherence is good, and the results are really there. So personally, I do always after CDK4/6 inhibitors, everolimus in second line, and I think it's a good option. Now, there is a nice question here. If you allow me, Dr. Shamsuddin,
yes,
is it
yes.
possible to add CDK4/6 inhibitor to aromatase inhibitors if progression on aromatase inhibitors because of limited availability of fulvestrant? Sure, we can do that. Remember, again and again, here we are converting, on est en train de surpasser la résistance. We are overcoming the resistance of. So again, mTOR inhibitor alone is not efficacious. And when Nolvadex is no more efficacious, if you add it, or aromatase inhibitor, if you add the mTOR to the aromatase inhibitor, you are gaining again the sensitivity of the estrogen receptor. So we are overcoming the resistance. And the CDK4/6 inhibitor is the same. We are overcoming the resistance. So again, this is the importance of understanding these different pathways that we have in the tumor. And this is what Dr. Shamsuddin said. It's not only about targeting different pathways, it's also about targeting different levels of pathways. So yes, the answer is yes, we can.
Thank you. Puis, si on n'a pas le fulvestrant, on peut changer de classe d'anti-aromatase. Donc voilà, on peut passer au stéroïdien si on a fait le non-stéroïdien ou inversé.
Exactly.
Okay, Fadi, so maybe we move on to the closing remarks. I think it's time.
Yeah,
so the closing.
Thank you, Ali, for the excellent moderation. I think it's one of the few times that we did it on time. Just to announce that our next activity will be next Tuesday, July 13th, about hematological malignancies. Thank you for all the participants, speakers, and panelists. Dr. Fadi, the floor is yours.
Thank you all for your participation. We are really glad to have you among us. Please, if you have any suggestions, any comments, I will be very glad to receive it through Science Pro, through our president, Dr. Sam Al-Khatib, the president of the AMAC, or directly to me. Thank you very much, and see you next week, hopefully. Thank you.
Thank you. Thank you.
Thank you.
Bye-bye.
Bye-bye.